Hello, welcome back, everyone. So I hope that this morning's sessions really kind of whetted your appetite for, after recognizing what the issue is, for us looking at what can we do about it? How can we become competent in caring for ourselves or caring for someone else that is struggling with addiction and trauma, or addiction and or trauma. So I'll get the old clicker here. So we're going to talk about competent caring. I say that because many times we can be well-intentioned in our caring, but we're not knowledgeable. And we can inadvertently re-traumatize when we're trying to be helpful and healing. And none of us want to do that. And so a little bit of knowledge goes a long way, right? So here's a quote, and I couldn't find out who said it, but here it is anyway. The more pain you cause people, the more you shame and isolate them, the worse they'll feel about themselves. The more suffering you impose, the more you strengthen their need to escape. And I talked about how in the past, when it came to addiction, we used a lot of shame and blame. And there are subtle ways that we still do. You know, for example, sometimes, is that my phone? Oh, gee, mine has the same ringtone. We have so much in common. But in the addiction field, there's still subtle ways that we can shame people. You know, I talked to a woman last week. She's had 3 years clean and sober. And on the weekend, she was alone in her sister's house, and there was a bong on the table her sister uses. And she took a puff and then stopped it and then asked God to forgive her. And she came back and she was full of shame. Like, I have to start right from the beginning again. I was on step number 8. Now I have to start on step number 1. I said, don't be ridiculous. You know, you had a lapse, you had a slip, you recognize it. Let's analyze that. Let's look at why that happened and carry on. Keep moving forward. Because if you've done this work long enough, you know, even though you don't want to tell people, hey, guess what? Relapse is part of recovery. The fact is that relapse is part of recovery. And for someone like her, that happened. She shored up what happened in that moment. It was situational, and she can move on from that. Coming into the rooms and saying, I relapsed, I'm back to the beginning, my 3 years are wiped out, you know, would tap into her trauma. It's shame-based. So that's not my approach. And the more you shame and isolate them, the sneaky one is shame. How do we shame people? We can shame people by our attitude, by being dismissive, by looking down our nose at people, by making them feel like they're less than. And we can shame them in our language. You know, I don't like the term that says you have character defects. The last thing I need with my squashed, beaten down self-esteem is to hear, oh yeah, and by the way, you're defective. That doesn't work for me. There's other ways of saying that. If you said to me, you know what, you have some maladaptive coping strategies that might have helped you at the beginning, but no longer serve you. That's the same thing. You know, that's the same thing. It's longer. But what it says is that you've got some things you need to upgrade to be more effective, rather than saying you're defective, you have defects. So we want to be careful of how we're communicating to people. We want to be careful that we're not isolating them, you know, that we go, you know, she had 3 years, but now she blew it. You know, I was thinking she was a great example, and, you know, and That's a little different, I think, than if she went out for another 3 years using. But nonetheless, we have to just be careful, because we don't want to push people into the feeling of such dark shame and self-loathing that they're going to feel like they have no other option but to escape. So what does trauma-informed addiction caring look like? And some of these things, they work for whether you're an addict alone, or whether you're traumatized, or whether you're a traumatized addict. We want to provide a community of support. We want to provide a caring community around that individual. You may feel like, but I'm the only one that this person trusts. I will not be the only support person in your life. I won't. You know, if there's no other human beings that are going to be supportive to you, I'm going to give you the name. So at least you've got the stress center, at least you've got, you know, you've got other contacts, at least you've got other possibilities. But I will not be the only number that's in your phone book. Because healing comes in community. Healing comes in community. It doesn't come onto an island, it comes in community. Oh, I used to like that song, you know, I am a rock, I am an island, you know that one, you know, because I used to feel like that. That's what I was. It was separate from everybody. And many people are coming to us and that's what they feel. But healing comes in community, and that's caring community. And whether that's doing a circle of support, you know, within your church or within your program, maybe you have a person and they're acting out as disruptive, you know, then what you do is you surround them with people that are willing to be supportive to them, people who have learned about boundary setting so they're not rescuing, so that they're healthy, you know, where one person is their buddy for this week, someone else the next week, and then once a month, these people get together to talk about how they can be a good support to the individual. Because, and that is only supposing if you can actually get volunteers that are willing to help out. But it doesn't have to be a huge, huge time commitment. You're being part of a community. So anyway, I can't belabor that one point for the next hour, but providing non-judgmental support. Well, that should stand to reason, but sometimes we're judgmental. Sometimes we have to ask ourselves, why am I asking this question? You know, they've come to me, maybe the individual comes and you're not equating that they've got hardly any boundaries. I mean, you might have picked up on it when they said, hey, hi, I'm Susan. I was raped at 5 and I was sexually assaulted at 12 and da, 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 da. They're spilling it out because what they're doing, what the individual's doing is re-traumatizing themselves, and they like the feeling in their body of having a nervous system that's jacked up. And you're getting titillated, don't you like that word, titillated by their story, you know, and you're asking questions that are coming out of curiosity more than care. You don't need to know some of that story, not good for them to say, not good for you to hear. And so I stop people, you know, shortly after hello, when I realize that they're going to go into that long story, I'll stop them and I'll say, whoa, you know, I've already heard enough to know that you've been traumatized. You know, let's talk about how to create a safe container to hold your story of trauma. You know, and not good for them to say, not good for me to hear. I want to build up confidence in the individual. I want to be strength-based. I want to be able to focus on the things they are doing right, and then to encourage them to expand that. I want to build up self-love. Well, that's like a short little sentence that takes a long time, you know? When you loathe yourself, when you hate yourself, when you know, didn't have love shown to you and you don't show love to yourself, it's pretty hard to accept self-love. Today at lunchtime, we were talking about being with teenagers. And for a time, I had a contract at the youth teen shelter for homeless teenagers from age 12 up. And And if you think that you're going to go work with teenagers and you're going to win them over by your love, you better rethink that one. Because what do predators do with teenagers? Oh, they groom them. They groom them. And your well-intentioned, loving care to them, saying lovely things to, and stuff may be perceived as grooming behavior. And so, initially you need to earn the right to get that close to some of the teenagers. And how do you do that? By consistent, regular contact, right? You're not going to do it all in one session. So if you're part of a ministry group that's going to go into some socio-depressed area and you think you're going to go in and just win them over by your love in your first evening of outreach, and then you get discouraged after 3 months that you haven't led more people to the Lord and you decide to quit doing ministry, that's not helpful. That's certainly what I've seen in terms of street ministry in the city over the 40-some years that I've done it. Church groups, and they always send their kids downtown to do street ministry. I don't know why. They want to introduce their children to the main dealers in town, but instead of bringing adults, into the inner city with training, but you always know they're not going to last for very long. And maybe I'll tell the story I told at the table. I was walking outside of the convention center in Ottawa, and Joe comes out and he says, "Hey, Susan, I just made $30." And I go, "Oh, Joe, what are you up to?" And he says, "No, it's legit." He said, there's a Pentecostal convention happening here. And he said, "I got saved 3 times. And I said, "What?" And he said, "Yeah." Read the prayer on the back of the pamphlet. I said a couple of praise hallelujahs, and then they each gave me $10. And then he just sobered up his face and he said, "They got what they wanted. They'll go and they'll talk about me at church, and they'll get kudos for having saved me, and I'm happy because now I have money I can buy my next hit." And I said, "Well, how come you don't do that to me?" And he goes, "Susan, you're here every day." Like, really? It's like, yeah, self-love takes time. Even accepting your love and care takes a long time. Don't be afraid if people push back against you, and not believe that your motivation is true and real. Building trust takes a long time. Maybe the individual will never truly trust. And trust will be incremental, really small. And you may spend years with a person. And, I had one person say to me, "Susan, I'm just starting to begin to trust you." And I said, "Oh, that's good. It's been 5 years, that we've been meeting. It's good you're starting to trust, but it takes time, right?" We want to repair damaged relationships, and we recognize that people have been really hurt in relationships. And so that's where some of these concepts come from, trusting, loving, caring, whether you're congruent, that what you're exhibiting on the outside is really what you're feeling on the inside. Takes time. Healing past wounds. This is what our goal is. Skilled caring, we want to help people through their traumatic experiences, even the traumatic experience of recovery, which is a tough experience, to uproot dysfunctional feelings and behaviors. We want to show them that if you want to change your behavior, you have to go into your thinking. When you go into your let me start again. When you change your behavior, you got to go into your feelings, and you got to trust and know that feelings can lie to you. So then you go into your thinking, and then you ask yourself, is this feeling the truth? And then you go into your core values. And that's how you're going to change behavior. And so, realizing that what you feel may not be the truth is pretty discombobulating. Like, You know, you got to feel it to heal it, we've heard, but sometimes my feelings are not telling me the truth. Sometimes they're reinforcing old lies. And so we have a lot of untangling to do. There's a tangled web of feelings tied into behaviors, tied into memories. We want to be able to teach relapse prevention techniques, not just to the addict, but also so that the person can have emotional recovery. And so I had a woman in my support group say to me last week, she was feeling very, very nervous because her child had said she was going to take a trip on Thanksgiving and wouldn't have her over for dinner. And she started, you know, talking like she was back in the victim stance. And they needed to remind her that that victim posture that she had lived for many years was one that she agreed no longer served her. And then she went, oh yeah, you're right. And then she switched over and said, yeah, there's things I can do to take care of myself. And so we want to make sure, try to help people not relapse into old behaviors or into finding mood altering ways to change what they're feeling. Teaching stress management techniques, teaching responsibility. Skilled caring is also about reducing and alleviating some of the withdrawal symptoms, whether that's withdrawal from a drug or whether that's withdrawal from a behavior that no longer really serves the person anymore. And we want to recognize that it's not as easy as just stop that, you know, just say no. It's not that easy. But we want to be able to offer supports and encouragement, you know, to help them go through the withdrawal, uncomfortable feelings, reducing cravings and the temptation to relapse. You know, people, places, and things. So we want to bring to the forefront the fact that there are stumbling blocks in terms of relating to certain people, certain places, and certain things. We want to help the individual find out what their own triggers are, what triggers them to want to start to use. And we'll be looking at that in a minute. Okay, we want to reinforce what's healthy, what's good in the environment. So it becomes really important to have awareness that when we become self-aware, then we're able to address, you know, traumatic issues and the kind of issues that leave us vulnerable to addiction. But because this process inevitably involves pain, you know, the process of healing can be quite painful at times. That's why we don't tend to want to look at some of the issues. That's why we back off, you know, or we decide to go into magical thinking. Yeah, but you know, God is going to heal me. If I go to this convention with this healer, then I'll be healed. And, you know, just looking for ways that are, oh, I wished I could have found that magic in my own healing. You know, couldn't somebody just poof, presto, healed, you know, like that? And yeah, God could, if God wanted to, you know, I mean, God can do anything. But for me, my healing came through blood, sweat, and tears. It came, you know, through wrestling through my issues. And sometimes it isn't until we experience a crisis that we become aware. You know, the crisis happens, and then we have what we call an aha moment, right? Where we go, ah, I need to do something. My life's not working anymore. So we're going to look at what we call, this is by researchers called Proshanka and somebody else, forget his name, the stages of change, the 5 stages of change. So if I want to change something in my life, there's a process. Usually I start with a pre-contemplation, which means I'm not ready to actually change, but I'm kind of just thinking of the idea, you know? Oh, I think it would be great to go hiking except when I walk half a block, I'm exhausted and have to sit down. But it would be nice if I could actually hike. Contemplation. Well, you know, if I went and got exercise and maybe even saw a physio guy, then I might be able to start hiking because I could strengthen my body. And preparation. Well, I made an appointment to go see a physio guy or a trainer or somebody that's going to help me get the old body moving. And then I'm in action. I'm now doing exercise, and now I'm trying to maintain it. So I have a guy like that. And a year ago, I started seeing him. Well, January, my goal was, I want to be on the floor and be able to get up on my own steam. For some of you that can just hop up and down, you know, I used to do that, but I hadn't done that in years and years, and there was no way if I was on the floor, I was staying there. And so I can tell you that now I can go down on the floor and get up on my own steam. And so, but that took preparation. It took first exercise in the arms and then exercise in the legs and then, you know, doing all that stuff. And it's a process. There were stages of change. And it's the same thing with the addict, with somebody that wants to change their behavior, who's been traumatized. They want to make major changes in their life that they'll go through initially. You know, I'm not ready. I'm not ready to be sober yet. Thinking about it, but I'm not ready. And then I'm getting ready. I'm thinking about it more, and I'm thinking maybe a bit of a plan. Now I'm ready. I'm going to start on this particular date. Now I'm doing it. Now I'm going to learn to maintain it. Okay. You want to ask the individual. This is like Jesus going to the pool at Bethesda, where poor old blind Bartimaeus is sitting there, and Jesus asks him if he wants to be well. You know, and that's a question you want to ask the individual. You know, do you really want to make some changes in the way you're living your life, in how trauma has impacted your life, in how the addiction is impacting your life? And one way of kind of measuring that is to scale it 1 to 10. So, you know, you're in your active using, and you know, you tell me you want to change your life. Where are you at in that change process? Where do you think you're at? You can either do in one of the 5 stages of change, or you can do a 1 to 10 scale and see if that scale doesn't move closer to actually making the decision of wanting to change. So, yeah, so this is a given. That's everything we've talked about, that trauma and addiction, we need to work on both issues simultaneously. That means in reality, the individual is going into a drug treatment facility that doesn't address trauma, that ideally they have somebody that they can talk about the trauma feelings that come up for them. You know, in a perfect world, we would have counseling that was accessible to everybody, you know, but it's inaccessible to a lot of folks that are economically challenged. And so we want to be that friend that can come alongside, because as soon as I take your medicine away, the trauma is going to come up. And having run a drug treatment center for many years, I ran the Salvation Army one for federal parolees. Yeah, the behavior would come up, and then I'd be forced to exit them from the program. And they'd get exited, and then they'd come back around again the next term, in and out, in and out. I met some folks that had been 30 times in drug treatment facilities. The free ones, not the expensive ones. Yeah, in Ontario, you get 3 strikes, you're out. You get 3 chances at free treatment, and then you have to pay for it. So it's, we really need to be addressing both, but that would require actually training your staff. And many of these places have got staff members that receive little or no ongoing training. So one of the models I use is called the Triphasic Model. And it's not that I'm going to teach you how to be a therapist, but I think this is just a good model to use generally when you're coming alongside somebody that has expressed a trauma history. And there's 3 phases to this model. The first is safety and stabilization. The second, remembrance and mourning. And the third one is reconnection. So it's by Dr. Judith Herman, who you might remember was one of the first people to identify post-traumatic stress as being something that happened to folks other than just soldiers. So the first step always is safety first. Being mindful of safety, asking a lot of questions, giving choices, asking people, would you like to talk about this now? Just giving that buy-in to however you are wanting to direct that conversation in a healing, soothing way. And that involves encouraging the individual to create a safe container inside themselves in order to hold the traumatic story until such time as the traumatic story can go from being here to being moved into the past. So we do that through mindfulness. And if you don't like a Buddhist term like mindfulness, we can call it Christian meditation, or we can call it something else. But essentially, what it is practicing being in the present moment. So some exercises that you can do, most of us have cell phones. You can say, okay, today I want you to go for a walk and I want you to photograph things that are blue and round. Because you want to see beyond the surface. You want to be very much in the present moment seeing, or you might do shapes and images or whatever. And it just becomes an exercise in being fully in your body in the present moment. Mindfulness can involve prayer, spending time in prayer, being focused. It can involve visualizations where in your mind, we can use our imagination for our healing, where we get a happy place in our mind. Maybe we love it by the cottage by the ocean, or maybe we love it at grandma's house, smelling the cooking or something that becomes a safe place that we can let our thoughts drift to. We can, mindfulness can be prayer, meditation. It can be going into our 5 senses, seeing things that are very soothing for you, looking at photographs that bring about good feelings and good memories for you, watching something that is uplifting on the TV, probably not Criminal Minds. Being aware of the garbage in, garbage out principle, that we want to feed our mind with things that are healthy and wholesome, that we want to be aware of things we can hear. Oh no, maybe seeing is also being with family or friends or people you love, seeing your pets, these sorts of things. Hearing might be, make a playlist on Spotify that is soothing music for yourself. Music to play when I feel wobbly, so you can listen to that music and it takes you into a good space. Or hearing the sound of children laughing, or, paying attention to the hearing. Smelling, maybe there's a certain smell that you just love, the smell of pumpkin spice, or I don't like it, but I like lavender though. But there may be a smell that you really like that just is like that. It's also recognizing your breath. And we'll spend a little bit of time later about that, but taking deep breaths, oxygenating your body. It's very hard to experience, traumatic responses, even having, what's that feeling when you feel like you want to use drugs, but I'm getting a mind blank, but craving even helps with cravings, that you can slow your body down. Very hard to experience that when you're in a muscle relaxed, oxygenated body, right? So mindfulness, grounding. and I didn't go through all the senses. We'll talk more about that later. Grounding is being very firmly planted. You know, I'm here, I'm now, I'm very aware of it. You're sitting in the chair. I want you to be really aware of your arms. Where are your arms connecting? To the chair, to your face, to, you know, where is your butt connecting? What are your knees doing? What are your ankles doing? Being grounded here and now. Some people will have like a ring that they keep on their finger. If you've got somebody that slips back into a very much a childlike state when they get really anxious, tell them ahead of time, well, let's take your ring and let's just pray, knowing there's no magic here, but we just pray that when you touch your ring, it reminds you that you're an adult here and now. And we just kind of take that ring as a transitional object that we infuse with meaning. And so when the person is scared and you can see the childlike part of them coming out, you know, you go, feel that ring. What does it tell you? What does it remind you of? Oh, that I'm an adult, that I can handle this. So transitional objects are good. Might be the ring, you might have a little stone for the person or something that you give that person that ahead of time you've prayed that it would be a memory for them, that in fact they can handle their present situation. So much of what I'm talking about is self-soothing, and many of us as children, we weren't soothed. You know, I'll give you something to cry about. You know, we were not soothed, and we need to learn how to soothe ourselves and to use the metaphor that Carl Jung brings up about the inner child. You know, that here I am, I'm an adult, I'm here, I'm, you know, however old I am, and you know, but when I'm scared, I'm that 8-year-old child again that used to always get beaten up, that used to get locked in the closet, that used to be hurt. And I need to be able to know that I can be a good parent to the child that's within me. And so I want to listen to that part. And how would I take care of a child that's scared like that? Well, then I need to soothe myself. I need to care for myself. And that becomes really important. We need to know who the safe support is in our life. And by that, I mean, you know, who are the people that you feel the safest with? And, you know, you want to be able to, at some point when you're not upset, be cultivating, you know, a list of, you know, you may only have one person or two people, or not one person, more than one person, but to create, you know, a few people that are safe people that you can call and say, you know, am I interrupting you right now? Because we never know when we interrupt people when we phone them. And do you have maybe 10 minutes that I could just talk to you? And a safe person, most people maybe can give you 10 minutes. Prayer is important too. We need to feed into ourselves, to remind ourselves, especially if we don't feel it, that we are beloved of God, that we are, you know, fearfully and wonderfully made, that even our coping strategies that are causing us problems now were incredible, that we were able to discover those strategies to even survive to this age. And that God has a plan and purpose for our life, not to harm us, but to prosper us. And we need to be fed that, because some of us may not feel that. You know, some people feel it, you know, and they go after the feeling, but some of us don't ever feel that. I was quite interested when a book came out on Mother Teresa, and she had written these private letters to a priest, like a journal, only he was like her spiritual director, and asked him to never disclose them. But after she died, he published a book, and being curious, I read the book, but I was really interested to see that for most of her life, she did not feel the presence of God. She knew it, but she didn't feel it. And I thought, wow, that's interesting, because I don't often feel it, but I know it. You know, I hang on to what I know, but it's not like I get warm fuzzies, not very often. Oh, this just went down. I'm supposed to wiggle this around to make it work again. Oh, I did it. Okay. Techno savvy. You know, and meditation. We talked a lot about there being a physiological response, that traumatic memory gets encoded right into the body. And we have a vagal nerve that runs in our body, one of the biggest nerves in our body. It runs from the pubes up to the back here, way back of the throat, and it goes around all the major organs of the body. And we tend to hold a lot of stress in that area, you know, when we feel like tensed up, when, you know, our nervous system feels all jacked up. Sometimes, you know, we've discovered that vagal nerve is being affected. And so one of the exercises I learned from a Dr. Eric Gentry, he's a wonderful Christian trauma therapist, and he's on YouTube. He's well worth listening to. An exercise you can do to calm down your nervous system is you do a Kegel. You all know what a Kegel is? I'm doing one right now. So it's you do a Kegel, and at the same time you hum. Some people say, you know, stick your tongue on the roof of your mouth when you hum. Well, because the nerve endings are at the back here and are down there, and that may calm your nervous system down. So there's various exercises that you can do to calm down that vagal nerve. It's hot in here, isn't it? Yeah, I know, hot air just coming. All of this in the first step is to make a safe container to hold the trauma story. We want to teach healthy diversions. We want to establish some accountability. But some people can spend, you know, a year or more just in the first phase. And we're not even talking specifically about the trauma at this point. We're just learning how to regulate the nervous system and regulate the body. The step 2 is trauma remembrance and mourning. So I already said that I don't have to hear the story of trauma to work with your traumatic experience. We can ascribe new meaning to the traumatic event. So for me, my mother was extremely abusive, and I used to think she was the wicked witch of the West. Like, even when I was an adult, you know, that would be my thing. She's the wicked witch of the West. And she was mentally ill. Our home was like a horde. She was very violent, out of control. And it wasn't until I started studying trauma that I realized, what would it have been like to be 15 years old when the war broke out in Nazi Germany and she lived near the front lines? What would it have been like when the Russian soldiers came in and raped all the girls in the village, including her? What would it have been like? And I was actually angry at first, because I wanted to keep thinking she was the wicked witch of the West. But, you know, but to actually understand that, what did she know about parenting? You know, what did she know about how to cope and how to live a healthy life? She didn't. She was, you know, so troubled. And in the end, before she died, she was more and more split. Sometimes a little girl would phone me up, and I lived far away. I stayed in Ottawa. They moved to Vancouver Island, and she'd phone up, and I wouldn't know who would be phoning me, which part of her personality was calling me. And then I got the call that she'd committed suicide. So I needed to ascribe new meaning to my trauma experience, you know, and And that was very important in my healing. Important to note that there is no medication specifically that's going to cure trauma. Yeah, we have medication to help you with depression, with anxiety, with all kinds of spin-off symptoms, but we don't have a pill that's going to take away a complex PTSD or PTSD. So it's that's frustrating in our society, our microwave society that wants a quick fix, that wants everything taken care of. And it's the same with addiction. It's a process. It takes time. And like I said, with post-acute withdrawal, it can take a long time. And you need to be committed to the lifestyle change, the process. I think that, you know, if you're looking for a therapist, you want to find one that ideally that is trauma trained, but at least trauma informed, because many are not. And I found it very interesting when I went to the World Congress on Trauma in Ireland to see how much more advanced they are in what they offer in terms of trauma treatment than what we do in North America here. Because even like I said earlier, complex trauma has been on their books, on their diagnostic, as a diagnostic label for about 12 years now, where it's not even made it to the DSM here in North America. There is no one specific treatment for trauma. Now, isn't that a bummer? Because wouldn't it be nice if, you know, if there was one thing you could just do and then it would be done, right? It's not. There's all kinds of therapies and there's all kinds of new stuff happening. And then there's new people regurging old stuff and putting new names on old ideas and calling it new therapy. So you need to find what works for you. You know, there's rapid eye movement therapy, EMDR. Some people find great success in that, and that does bilateral brain stimulation as you're telling the story and trying to reframe your story. And some find great relief in that. Some people find IFS, internal family systems therapy, a good therapy that looks at the different fracturing in the parts inside. You know, most therapists, Gabor Mate's got his own kind of therapy. Bessel's got his own kind of therapy. Gentry's got his own kind of, they all have their own kind of therapies that all have similar elements, but different emphasis, right? And so I think it kind of goes back to what, was it Carl Rogers that said that it isn't always so much the therapy that you do, but it's the quality of the interface between me as a counselor and you as the person seeking counsel. You know, whether I'm attuning, whether I'm listening, and whether I'm skilled in my listening in the sense of understanding, you know, how trauma works and being able to validate your story and to believe you for the next steps that you could take to better your life. So, okay, and we've talked about this too. We want to resist re-traumatizing people. You know, maybe you think the process is too slow and you've got their treatment plan. Well, no, you're not doing treatment plans, but maybe you have an idea in your head of how their healing should go, a time frame, let's say. And they're slow and not following your time frame. And you might think, oh, they're malingering, they're just not, you know, as into it. Everybody has got to be master of their own recovery. They've got to own their own process. And it's going to be different for each person. And so it's something that we need to encourage the individual. I tell people right from the get-go that I believe you're an expert of you. You live inside your skin. You live inside your experience. I don't. If I'm maybe, I don't know, expert, but if I'm good at anything, maybe it's asking the kind of questions that help you find the answers and direction that you need in order to make positive changes in your life. So in that phase here, remembrance and mourning, what I didn't mention here is a very important step is grieving. Grieving is a really important step because you need to grieve what happened to you. You need to grieve the childhood you never had. You need to grieve. I needed to grieve that I don't have a family, that I had no idea how family works. Oh, I read a book about it, so I have a bit of an idea. But and I do observation. I'm staying at Lydia and Wayne's place, so I'm observing them, you know, as a family case study. But for me. But it's not that I have a lived experience of that. And so I can't remember what I was starting to say. Oh, grieving. Yes. Yes. So, you know, I've needed to grieve opportunities I didn't have. You know, I had an interesting experience where I got called to court for one of my clients. It was in a child custody case. And their lawyer wanted me to go up as an expert witness. And I said, I can't do that. I'm not an expert. I'm not a doctor. They're not going to listen to me. You know, oh, well, the judge is willing to test you to see whether you could be an expert witness. So, okay. So I go on the stand and the prosecutor, he's a, you know, I got a pretty full resume because I've been working for a long time. And he's looking through everything and he goes, well, it comes to the court attention that you don't have a master's degree. I said, no, I don't have a master's degree. Well, comes to the court's attention that you don't have a bachelor's degree. I said, no, don't have a bachelor's degree. And he said, well, you probably don't have a high school diploma. I said, no, I don't have a high school diploma either. And they're looking at me and I said, but, you know, I've got the top credential for, I've done trauma studies for 30 years. I've done addiction studies and I've been working in the field all these years and I've, you know, and I do have like kind of accolades and stuff. And the judge said, well, it's come to the court's attention that Reverend Brent got her education through non-traditional means. And I was declared an expert witness in the area of trauma and addiction. Not so easy these days to get away with that. I mean, I think I told some of you that getting into nursing school, I applied 6 times, you know, and at first they just laughed at me and said, people like you don't become nurses. And because I just come off the streets and I'm telling them, Jesus wants me to be a nurse. And that didn't go over so well. But then eventually they said, are you going to keep coming back here? And I said, yes. And I have tried to educate myself to be the best I can be to people who can't afford, you know, someone that has my education. And but it's still not going to be good enough for some arenas. And that's okay. So I could mourn the fact that I never had the chance to come to a place like this or go to a university where I, you know, stayed in for a period of time. I did do part-time for many years at Queen's University, and I do have, well, that's probably just another certificate. I have enough diplomas and certificate to wallpaper my bathroom, but anyway, there you go. The third step is reconnection. Okay, so this is where we start being more outward looking. At this point, the symptoms have calmed themselves down. We have a much better understanding of our life. We have a much better understanding how to regulate our nervous system, how to put our story in context, and we're starting to learn healthy life skills. This is where we focus, issues of intimacy and identity. Somewhere along the line early on, you know, we've probably uncovered that we're very codependent. You know that word codependent? That's when I'm drowning and I see your life flashing in front of my eyes. And because when I ran the drug treatment center, it was about the second month sober that each one of them wanted to become an addiction counselor. And everybody knew everything there was to know about addiction recovery. And they were all wanting to help everybody, but not focus on themselves. So we need to focus and maybe in some cases relearn about identity and intimacy and relationships. And this is where maybe we do work on anger management, and we do, like I said, life skills work. We learn how to live feeling empowered and connected to community. But there's always relapse potential. So how many of you know HALT? Hungry, angry, lonely, tired. Yes. So that's a nice little snapshot of what can trip you up into relapse. And before relapse ever happens, relapse happens in your thinking first. It happens before you actually relapse. So I asked this gal who saw the bong there, who smoked off of it. I said, so when did the relapse happen? Well, I just saw it. And I said, no, tell me when it happened. You know, and she was starting to, you know, awfulize her recovery. She was starting to go, oh, by now I've got this taken care of. You know, it's legal. I should be able to have a puff. And she was starting to talk to herself like that. And so we needed to do a deep dive into that and shore that up and say, well, is that okay? You know, is that okay for you to have a puff when what she felt she had been addicted to was pot in itself, because she was smoking from morning till night, and totally neglecting her children and everything. And so relapse always happens before it happens. So whenever somebody relapses, I want to take them back, and I want us to find, you know, the time frame or the moment that they started entertaining the thought of relapse, because it's always planned before it happens. So social isolation, alienation, not trusting others, thinking that the program sucks, thinking that, you know, that you can't stand AA or treatment or anything anymore, or that, you know, it's okay, I got this, I can handle this, you know, yourself. Spiraling into old feelings of self-loathing, of unworthiness, of, you know, toxic guilt and shame. That can lead to relapse. Isolation, how hard was it during COVID? Everywhere the message was isolate, isolate, isolate. The last thing that we should be doing is isolating, except we needed to isolate, right? It was a hard time. And of course, addiction use just skyrocketed. It just skyrocketed during that time because people had a hard time coping with just themselves. And some people may continue in their recovery to just feel like they can't stand to be alone. That's a big learning hurdle too. If you've always escaped, to learn how to spend time with yourself and be okay with that. You may start developing a great fear or an unrealistic expectation about how you handle your emotions or your thinking, or you start to go into, what do they call it in the 12 steps? Stinking thinking, but without putting that value judgment on it, getting into a place where your thinking seems to go around and round, like the hamster wheel goes round and round, and you're not actively using your tools to slow that down. And then sleep disturbances, flashbacks, nightmares. You want to escape. So the general approach when we're talking to somebody in recovery is to use open-ended questions to encourage the person to talk. So that means avoiding the why questions. So why did you do that? You know, and doesn't that sound like a finger in your face when I say why? So you do, you know, what was it about that behavior that made it so attractive to you? You know, how is it, you know, that in your mind that it was okay for you to act in a certain way, to use those other kinds of questions, you know, who, what, where, but not why questions. And of course, we want to have appropriate attunement. You know, the attunement, remember I said that's like the mom looking at the baby and really focusing and letting the person know that you're there. Doesn't necessarily mean having strong eye contact, because in some cultures, it's not good to just stare somebody down. You know, I'll look at the right ear, you know, and put my gaze over a little bit. And like in the Indigenous community, they're not so keen like we are to just, you know, maintaining eye contact means I'm really there with you. You know, that's seen as intrusive. So you want to be culturally appropriate, but you want to convey warmth, and you want to convey that you really do care. That, oh, you just care because you're getting paid for it. No, I care because I care about people and I care about you. And you want to be able to communicate that. And because so much of communication is nonverbal, we want to communicate that with how we're sitting, you know, how we're looking, how we're listening, how we're presenting to the individual, right? Because that's what I find hard about doing video counseling now. You know, I've got to keep asking people when I see them like this, I got to keep saying, what are your feet doing right now? Because I can't see them on the screen, you know, but the whole body gives a lot of messages. Yeah. We want to give make our reflections simple, and we want to be sure that the timing of our reflections, just because I'm aware of patterns of behavior and you tell me this piece of information, and I right away know what's going to come after. I'm thinking I know. You know, I don't want to prematurely birth you. I don't want to pull the rose out of the rosebud. You know, I got to be aware of timing. And I've got to be, you know, conscious of that. You know, would you like to know what I think? You know, invite the person to let you know if they want to know, you know, instead of going, oh, I know what's wrong with you, and just barrel it out. You know, we want to be warm and we want to be sensitive, but we want to make sure that what we do observe, that we communicate in simple language that's easy to understand, so that we go, oh, you're having a catharsis. Well, that's probably not what you're going to say. You know, you're going to say, oh, maybe this is an aha moment or something that's more understandable. Paraphrase, to let the person, I put patient here, you can tell my thinking, hear their own words again and to convey understanding. So, so paraphrasing is taking what the person said, maybe using different language to communicate the thing back so that you can develop clarity and understanding. So sometimes I have people come in, well, almost every day I have people come in and say, oh, I just want to die. Well, I don't just run and call 911, you know. I want to paraphrase that. I go, well, you know, when you say that, are you saying that you actually want to harm yourself and kill yourself? Or are you saying that you just wish your situation would change? And of course, most of the time they're saying that they just wish their situation would change, or that they feel they can't cope. But you want to paraphrase back. One of the techniques that we use, that anybody can use, is some of the motivational interviewing techniques. And so, how are we doing time-wise? Oh, we have another half hour. Okay, well, I got to drink something, and then I just, as I glug, glug, glug. So the whole purpose of using motivational interviewing skills is we want to express empathy. We want to let the person know that we're accepting what they're saying and we understand what they're saying. And we want to show where there's incongruency, where there's a discrepancy between what the person wants in the here and now, and what their desired goal is. We want them to be able to see that with some clarity. We want to avoid arguments to limit resistance. So we want to figure out where they are in the change process. We want to roll with resistance and use it to move forward. So the person is resisting, but what are you willing to do? And we want to be, this is a slow process. We want to support self-efficacy, which is we want to believe that the person can help themselves, that the person has the energy and strength to make some of these changes. I'm not going to change you. You know, I don't have that power and control, nor do I want it. But I want to help you believe that you can change. So it's always good when, you know, if you meet with a friend that's got some problems, it's asking you to come over to help them. You know, I'm in a real mess. You want to have a clear understanding. Why are we meeting? What are your expectations? Maybe not say, don't say that right up front, but you might want to speak about what your boundaries are and what your limitations are. You know, okay, I'm not a counselor. I'm not a therapist. I can hear you. I can help you hear yourself. And, you know, you want to be clear. You want to be clear about your time and your format. Well, you know, I'd be willing to meet with you once a week for an hour. And then you want to be sure that you stick within the hour so that the person can trust that you're a person of your word and they can trust that boundary. You want to look at sort of the overriding concerns initially. We're not going to go in for the micro. We're going to start with the macro, and we're going, is that right? Macro, micro? Okay, whatever. It's, you know, we're going to go for the big issue before we start zoning in on the little issues, unless there's a safety factor. And then it's always safety first. We're not going to ask details about the traumatic experience. The person may want to tell us, but I'm not going to want to hear those details of the traumatic experience until I know that they've got a safe place in which to present the story, and that they're not, in fact, engaging in re-traumatizing themselves. And yeah, and even when I'm hearing, you know, the individuals coming because they have emotional concerns and distresses, you know, I want to ask, you know, what is the role that the drugs or alcohol or disruptive behavior is playing in your life? You know, if it brings you pleasure, how does it bring you pleasure? You know, what made you attracted to that particular drug of choice? You know, how can you find pleasure without that? And by replacing it with something that's healthier. You don't want to pull the rug out from under them. You know, well, you just got to stop all that, you know, without giving them other options and saying, you know, I'm willing to journey alongside you. You know, there's a church here, a group here, or something that's willing to surround you and encourage you. Together, we can do a lot that we can't do alone. That kind of thing. Okay. So one of the things in motivational interviewing is we want to elicit options from the person. So you've described the problem. What do you see as options that would help you change? And because you're dealing with someone who's been traumatized, you always want to ask permission before bulldozing in. Sometimes I'm not good at that. I just bulldoze, but I think it's good, you know, and it's respectful to say, would you like to hear my opinion? Would you like to hear more options? And would you like to hear what I see? And you want to provide information that helps a person move towards healthier options. And you want to help them sort through all the possibilities. Well, you could go into treatment. There's 6 treatment centers available, and you want to go through, you know, go through that with them. And then before you leave, you want to try to elicit a statement of follow through. okay, before our next meeting is, are you able to scope out these 5 places and come back to me with one that feels like number them 1 to 5, or some homework. I always give homework when people come to see me. Always something to think and follow through during the week that is going to be a step forward towards change. So we want to solidify motivation. Yes, safety stabilization. We talked about that. Importance of integration in mourning, and then reclaiming and developing a meaningful life. So there's part of the 4 stages of change. We want to ask people, would you like feedback? If you just want to talk about your problem and you don't want me to give you any feedback, I've got 10 minutes for you. If you want to talk about your problem and you want to hear some feedback, I have an hour for you. So which do you choose? Some people just want to talk about their stuff. Well, if they just want to talk about their stuff, maybe they're at the pre-contemplative stage. They're not ready to, and so, maybe you don't take as much time. And you tell them, well, if you just want to talk about it, well, I'll give you so many minutes, because you only sit so long listening to something that doesn't want any resolution. I don't know, maybe I got that wrong, but that's how I do it. Using a neutral tone, I try to use a calm voice. When the person is agitated, my voice maybe almost becomes musical. I know you're not feeling well. Why don't you take a deep breath? Model it, and and then you'll see that the individual may model your breathing and may actually calm down with the soothing tone of your voice. Yeah, if you're surprised or you go, you think, well, that's wonky, you don't want to react like that. You want to kind of be gentle and go, oh, isn't that interesting? Curious, and help them to explain their reasoning, but we don't want to be freaking on people and creating a startle response. We want to check if their information is accurate. Well, it's interesting you believe this, but my understanding is this. So where did you get your information for this? Do you have resources that I could learn more, and to look at the differences without saying, no, that's not true, this is true, and you want to avoid arguments, right? And keep giving information so people can make informed decisions. So, okay, so what's important too is your reactions to yourself. I may have a young kid in front of me, a teenager, that tells me a story that really kind of sounds like the story of my life. And if I start to identify and go, oh, I know exactly what that person's feeling and going through, because I went through the same thing. And I start to, in my head, put that on this kid, then I'm no longer listening to them and their uniqueness and their unique personality, unique experience. I'm starting to put my stuff on them, which isn't fair. And sometimes the individual put that back on me. Maybe I have a person that all of a sudden starts to think that when they see me, they see their mother and they hate their mother. And I get a response back like that. We call that transference and countertransference. And so we need to be aware of that kind of thing. If that happens, that we can address that. We need to be aware of the power dynamics that, sure, you might have someone that's coming and wants some help, but because you're in the position of wanting to help them, they may see you as in a position of authority, and they've always rebelled against authority. And they may put something on you that begins to complicate the conversation. And so you want to be as immediate as you can to say, oh, something interesting just happened here. Did you notice that the way you talked to me was, it kind of sounded like I was your mom or something. What was going on for you there? and seeing if we can't get back on track, that we're just two people, you know, one person. I just want to be helpful to you, and you're coming to me with the problem. Yeah, we want to be so careful of our responses and not underestimate the impact that our presence has in their life. Now, let me take my shoes off. They're hurting my feet. So sometimes we can get right off track and realize that we've gone down a rabbit hole with the person that we're trying to help. And it's okay to stop and go, oh, let's get back to this over here, you know, and to see if you can't redirect them back to the issue they came in to talk about. Because I have folks who come in sometimes, they'll say, well, how was your week? And they tell me all this stuff, and I just know they're not telling me what they really want to tell me. And sometimes I have to go, oh, let me stop you there. It sounds like you had a wonderful week, but I'm getting the feeling from just seeing how you're sitting there and seeing, you know, how your body is, that there was something stressful that happened. Can we talk about that? Oh, okay. And they go there. We want to be able to set goals too in our relationship, because you're not going to be a rescuer. I never believe in rescuing anyone unless they're unconscious. I always try to help people use the energy they have to help themselves. So I worked with a homeless friend, and he says, oh, Susan, can you hem my pants for me? I go, well, come sit down. I'll give you a needle and thread. You take one leg, I take the other. And, you know, by the time I finish one leg, he's got 2 stitches in, and then I might do the other one. But at least, you know, it's a participation. We're doing it together. And in some ways, helping somebody is a bit like a dance. Like, you know, the person that has the concern will take the lead. And, you know, I'll go as far as they want to go. And I might challenge them to consider going a little further, but they have to be willing to go. I can't make them. So we may do goal setting. So specific goals, SMART goals, specific, measurable, attainable, or what's the R? Realistic and timed goals. So yeah, I just want to get thinner. Okay. Specifically, what are you going to do? Well, I'm going to do this particular program. How can we measure it? Well, we get weighed every week. Is it attainable? Yes, it's attainable, because you're talking about 20 pounds. Is it realistic? Yes. And what time frame? In the next 3 months, you know, so that it's something you can go back and you can measure. So when the person is identifying a specific goal, for learning a new behavior or for maintaining some sobriety, it's okay to have specific goal measurements. It's I'm always saying to the person who is in their the throes of addiction, I'm always saying, is it bad enough for you yet? You know, does it have to get worse, you know, for you to consider making a change? Or is it bad enough now? And because if you don't know why you're making the changes that you're making, then you're not going to follow through on them. You know, and that means having right in the front of your head the negative consequences of why you're doing what you're doing, and having negative consequences as to why you're using and what goal you're hoping to attain. And so sometimes what happens, like I said, at the 3 months when my addiction clients know everything there is to know about addiction, is they forget the negative consequences, and they forget why they stopped using in the first place. And so that becomes really important, that stays at the forefront of the mind. Again, helpful people. You want to maybe do a cost benefits analysis. This is a good one too, where you get a piece of paper, you divide it, put a big cross in the center, pros, cons. So what are the pros and cons of not changing your addiction behavior? What are the pros and cons of not changing your trauma behavior? What are the pros and cons of changing your behavior in terms of addiction and in terms of trauma responses? That one's always quite interesting because there are good reasons, you know, why you used. I can tell you I never stopped using because I didn't like it. I liked the feeling of it. I stopped using because it started killing me. The negative consequences were so terrible. That's why I stopped using. But this was a very good way to cognitively put on paper so that you can see, you know, why are you making these changes? Do you really want to make these changes? So one of the things I wanted to close with in this section, we have 10 minutes here, is I wanted to talk about suicide screening. I think this is an important skill that we should all have. When you have somebody that is showing suicidal behavior or parasuicidal behavior. Remember, we talked about parasuicidal behavior as being self-injury and how that sometimes can lead to death, even though the individual may not be wanting that. But, you know, I ask these questions, you know, in the past few weeks, have you wished you were dead? Don't be afraid of bringing up the topic of, you know, do you think that you're going to kill yourself, or do you wish that you were dead? Because if the person's thinking about it, then, you know, they'll it's in their mind anyway. You know, if they're not thinking about it, well, it's not like you're planting a seed in their head and now they're going to start thinking about it. You know, it's you know, they'll be pretty quick to say no way. You know, in the past few weeks, have you felt that you or your family would be better off if you were dead? And you may hear people who are not suicidal that say yes to that. Yes, you know, I've hurt and damaged everybody around me, and I'm sure they'd be glad if I wasn't here anymore. But we're looking at the answers to all the questions. In the past week, have you had thoughts about killing yourself? Yes or no? Have you ever tried killing yourself in the past? There's many more factors that may play into somebody who is suicidal than just these questions. But these questions are good to give you an idea if this is the direction the person is going in. But if the person is giving away their possessions, I remember going to a party when I was in my 20s. This gal had, and she had presents for all of us that were precious things that belonged to her. And that night after we all left, she shot herself. It, you know, I've been alongside suicide quite a bit. Another factor can be if there's been suicide in the family. You know, some people, you know, then may think that suicide is a viable option for them. We want to ask, have you ever tried to kill yourself? And then I often ask, well, what did you do? And do you have a plan? But, oh yeah, and it does say if yes, how and when. Okay, if the person answers yes to any of the above, then I ask, you know, are you having thoughts of killing yourself right now? And so I do an assessment from those questions. If they answer no to everything, then the suicide risk is low. It may be not totally no, because they may not tell you. You know, I've had clients that, you know, I'll be starting to ask the questions and they'll go, yeah. You think I'd ever tell you if I was actually going to do it? They know the screening, but you're screening nonetheless. If someone commits suicide, it's not your fault. I can't own that as my fault. You know, when I've had a client who's committed suicide, you know, I can't own that. I always immediately you start to feel guilty and immediately you question and second guess yourself, but I can't be with you 24/7, right? I can't be there to rescue you. But if I sense that in the screening, if either clinically I sense you're saying no, but I think it's a yes, if I've sensed that there's danger because you've said yes to things, then I need to take other action. You know, so if they say no, 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 that means you don't have to do intervention unless your judgment tells you there's something going on here. If the person says yes to these questions or refuses to answer, then we consider that, you know, an imminent danger. And then the person requires STAT, which means right now really needs a safety or mental health evaluation. Hopefully the person doesn't leave until they're evaluated, which means then you call for help. You keep the person in sight, you remove dangerous objects from the room, and you call, what we do at our centers, we call the police, or in some cases, you might be calling a physician or a therapist responsible for the person's care. But what we do is we call the police. And I have a lot of young people that posture suicide, you know, that say, you know, I'm going to kill myself, I'm going to die now, and we'll call the police, and to err on the side of caution, because I don't know, you know, I don't know if you're going to do it or not do it. Over the years, I've known enough people that have done it that I'll take that cry for help and I'll get you help. Okay, so we've got 5 minutes, and any questions just in this section? It's quite warm in here, isn't it? Yeah, need a fan that, whoo, like a Marilyn Monroe fan. Any questions? Yes.
Recommend some good training for ladies for trauma counseling. So you mentioned a couple. You said it varies, depends on what works for that person. But is there something that just people who work with people who struggle could learn?
Yes, so I'm trying to cover a spectrum of different possibilities, and I hope I'm not talking too much like the therapist I am, but rather things that you could incorporate into lay helping. I think it's understanding the nature of trauma. I really like some of the teachings of Dr. Eric Gentry. He is a recovering addict, and he is a psychologist, a student of Dr. Bessel van der Kolk's, and he's got a lot of teachings online on YouTube. So you may find some really helpful stuff there. But Gabor Mate, his teachings also are very relatable, easy to understand. Gabor Mate, Gabor, last name Mate. He's from Vancouver. He did a lot of work in the downtown east side, but he's written some really stellar books that are very easy for the layperson to read. Like, he takes complex theories and he can break it down. And so his book, In the Realm of the Hungry Ghosts, it's called, talks about addiction and trauma. And his book, When the Body Says No, talks about the impact of trauma on the body and the increase of inflammation, that sort of thing. And he's got a new book out, which I haven't read, called The Myth of Normal in a Toxic Society. So I'm looking forward to reading that one and seeing what that one's about. And then there's a little bit more clinical online is the stuff by Dr. Bessel van der Kolk. But I particularly like those folks. And I like Dr. Janina Fisher too. She does what's called sensory motor psychotherapy, but some of her videos are very good in terms of exercises for the body, how to calm down. So yeah, that leaves us like 1 minute. Anyone have a 1 minute question? Janina, Janina. Fisher, Fischer.